now to Shirley Garcia from M Devices. Shirley is the National Community Manager at M Devices, and most of us already have met her at various conferences, and she's going to talk to us about M Devices products. Please start, Shirley. Thank you.
Thank you. Thank you, Sue. Yes, thank you. I would like to introduce myself. My name is Shirley Garcia, and I am representing M Devices. And yes, thank you for the opportunity to sponsor tonight's webinar. I would like to present today our two-way Foley catheter open-ended. If you can, next slides.
Oh, sorry.
Next one. So M Devices indwelling catheter range. So we have two-way Foley catheters, a standard bullet tip, and we have also the products that are going to be presenting today, the two-way Foley catheter open-ended. We also have a two-way Foley catheter timing tip and a three-way Foley catheter. Are two-way Foley catheters and are 8 weeks indwelling time, suprapubic approved, and also urethral. That's the feature of the night. So yes, our two-way Foley catheter open-ended and have two bilateral eyelets and an open tip to allows high flow urine drainage, symmetrical balloon, 10 mils, urethral, and suprapubic catheterization approved, printed incremental measurement markings, and long indwelling time of up to 8 weeks. Radio and 100% silicone, suitable for males and females from French 14 to 24, 40 centimeters length. I will leave you now with a video. Thank you. If you have any questions.
That sound.
Bilateral eyelets deliver high flow rates for urine drainage to support people who suffer frequent catheter blockages. It also features markings to aid catheter placement, and it is radio-paid. It is suitable for both males and females. Has an indwelling time of up to 8 weeks. This product is in stock now and available. For more information, please call me or visit M Devices website. Thank you.
Shirley, is that the end of your presentation?
Yes.
Okay, thank you very much.
What I was going to say, if you need, if you have any questions, and also if you would like to receive any product samples, please give me a call. Thank you.
Okay. Yep. Thank you very much, Shirley. That's terrific. TJ, thank you for coming this evening. Have you got your slides ready for Liz to display?
No, that's okay. I can display it myself.
You can do that? Oh, that's wonderful.
I hope so.
Okay. Dr. TJ Ong, I would like to introduce. I'm very pleased to do this. He's a graduate of Melbourne University and completed his geriatric medicine training in 2012. He works as a geriatrician at the Royal Melbourne Hospital, consulting in the Continence Clinic, conducting urodynamic studies, education and research. In his private practice, he visits aged care facilities to provide comprehensive geriatric assessments with a keen interest in dementia management. And to me, he sounds like an all-round very interesting guy, and I can't wait to hear what you've got to say, TJ. Please start.
Okay, well, thank you very much for the invitation, everyone. Today, we're going to talk a bit about Nocturia, and it's a great time to do it at nighttime, so welcome. Now, can you see my screen?
Yes.
Is this at full screen?
Yes.
Wonderful. Okay, so today we are going to do Nocturia, a very practical approach. Nothing too fancy, high-powered, but just a very simple approach that we can use really on a day-to-day basis in your clinic. So I'll start first with the ICS definition from 2018.
Yeah, don't
There's some echo.
So the first thing to say is that they
Could everybody please make sure that they're muted because we're hearing noise in the background?
Oh, of course. Yeah. Oh, good. Yeah.
Vicky
Sorry,
Green,
where's it coming from?
Vicky Green, can you please make sure that you're muted? Thank you.
Thanks
So
very
sorry,
much.
TJ.
That's all right, no worries. Okay, so nocturia by the ICS definition is the number of times that urine is passed during the main sleep period. Now, each void is followed by the sleep or at least intention to sleep. And as you know, that there's been a few iterations over the years, mainly because everyone is a little bit different. They've got the shift workers. It used to be defined as a complaint, but no longer. Sometimes people actually go to the toilet multiple times in a row without actually going back to sleep. Sometimes people can't return to sleep because of some other reason. And so now it's any number of times that you are passing urine in the main sleep period. So the prevalence of nocturia is quite high, in my opinion. For patients who come into the clinic, it's at least sort of 30% as in the EPIC study. But when you this is back when nocturia was defined as 2 or more, but certainly if you're talking about any number of times, I think nocturia will be actually much higher. And you can also see here that it's actually quite, the degree of bother is relatively high as well, either quite a bit or somewhat. Now, the thing to say here is that in the red here, we can see that how many people find that they have nocturia of 0 to 1, 2, 3, or 4, and how many people actually find it not problematic versus the blue bars, which are where it's problematic for the patient. And what you see is that when it is 2 or more times, then it becomes to be quite problematic for the person. And it really comes down to the reason is because of our sleep architecture. So when we go to sleep at night, so for example, a person has gone to sleep at 11 o'clock in the morning and they wake at about 7 a.m. What happens is that you are awake and you start to fall into stage 1 and stage 2 of sleep, which is your lighter sleep. And then after that, you go into the deeper sleeps, which is in stage 3 and 4. You cycle through to REM, which is where you have all these delightful dreams. And then after that, go back into stages, light sleep, deep sleep. And what you'll find is that in the initial stages of the initial parts of the night, you'll actually spend a fair amount of time in deep sleep. Whereas towards the probably close to the time that you're waking up, you actually have little deep sleep. And what happens is that if you interrupt your deep sleep for whatever reason, people will find that they actually do not regain the deep sleep, even if they sleep for just as many hours or longer even. And stage 3 and stage 4, which is the deeper sleep, is the most physically restorative sleep. So if you have say, for example, an 8-hour sleep time, what you'll find is that if you wake up once, you probably might wake up, say, let's just say halfway. you probably will wake up 4 hours or more. Whereas if you wake up 2 or more times, you're likely to break into these first 4-hour period where you have most of the deep sleep. So in Nocturia, we want to know a couple of things. The first thing is this FUST or F-U-S-T, the first uninterrupted sleep time. And this is where the first 4 hours is quite critical. Then we have this thing called the nocturnal urine volume, which is really the total volume voided during your sleep period. It should exclude the last void before you go to sleep, but it has to include the first morning void. Then on your bladder diary, you'll also find the 24-hour urine volume. And so if you know how much you've made during the night and how much you've made in a 24-hour period, then you can calculate what's called the nocturnal polyuria index. And if a person is produced more than 33% or more than 1/3 of their urine production is overnight, then that's called nocturnal polyuria. It's quite useful to know if what is the maximum voided volume in the total 24-hour period. Say, for example, if they, during the daytime, they might void 500 mils, but overnight, they're only voiding 200 mils. Well, it kind of gives you a different, it might guide you down a different road. But it's also useful, I think, to understand what is the largest single nocturia void, which is your nocturnal maximum voided volume. This is not critical, but useful information in my opinion. So I'll give you an example here. So this person has gone to sleep at 10 p.m. and they've passed out 200 mils before they went to sleep. Then they woke up at 12 midnight to pass 200 mils. 2 o'clock in the morning, 200 mils, 4 a.m., 200 mils, 6 a.m., 200 mils. And then they woke up at 8 a.m. and voided 200 mils. Then throughout the rest of the day, they have voided a total of 800 mils. So when we count the nocturia, we discard the 10 p.m. just before they went to sleep. But then we have nocturia 1, 2, 3, and 4. We don't count this because they're waking up for the day and don't intend to return to sleep. So nocturia here is not 4. The first uninterrupted sleep time, in this case, will be 2 hours. The nocturnal urine volume we discard the last void before sleep. So then after that, there's 200, 400, 600, 800, and we include the first morning void because this volume was produced in the sleeping period. So a total of, in this case, 1,000 mils. And if we then calculate the rest of the day, there's 800 mils, and then let's just say we add 200 mils. So then that's 1,000 mils. So 1,000 mils overnight, 1,000 mils the rest of the day, then the nocturnal polyuria index is 50%. Clearly, there's nocturnal polyuria in this case. So let's go through the causes of nocturia. And I do apologize that this is a very busy slide, but I'll just point you to this side here on the left first. So Carl Everett, back in, published this really interesting, I think, useful paper that really says that there are multiple causes for nocturia. There is, of course, what we know, the urological and urogynecological, things that we see, the overactive bladder. But he also said, look, don't forget about what people drink, how much salt they take, how much solutes they take. Don't forget about other nephrological reasons. So how much is the kidney pumping into this, whether they have diabetes, insipidus, or chronic renal failure. How about people who have congestive cardiac failure? They have peripheral edema. Their blood pressure is high overnight. What about people who have diabetes, sugar diabetes? What if people have a sleep issue? And they identified that if you find any of these causative factors, then really you want to diagnose this and treat this, each and all of them. And they really linked in all the different specialties, but the general practitioner as being a very, very vital cog in this. Personally, I find this quite difficult to remember. And so I quite like this way of thinking, which is where Nocturia, they broke it down into reduced bladder capacity, which is really an overactive bladder. And then they broke this down after that to how much are you pouring into it, which is nocturnal polyuria or 24-hour polyuria. And then other factors, which is really around sleep. And in this study by Cornu, what they found was that actually 88% of patients who complain of nocturia actually had nocturnal polyuria, or at least not necessarily a very high nocturnal polyuria, but there was a component of nocturnal polyuria. So it's probably very under-recognized. We in the continence clinics will always recognize the overactive bladder, but sometimes this nocturnal polyuria part is forgotten, missed, and certainly under-recognized. So I try to break it down even more easily because I think it's quite too complicated. So here are my takes on things. So I focus on the overactive bladder, and I go and ask my usual questions about, the overactive bladder, diffuse overactivity, constipation, prostatic obstruction, caffeine, fluid intake, UTIs, all the standard stuff we would normally talk about. Then I talk about how much do you pour into this bladder overnight? And then after that, is there a sleep disorder or others? Okay. So I'll go back and tell you how I actually ask patients. So I'll say, all right, well, tell me a little bit about you're very bothered by your waking up to go to the toilet overnight. Tell me a bit more. What time do you go to sleep? What time do you wake up? When time is the first time you wake up to pee? And then what time do you pee the next time and the next time? And what time do you wake up for the day? Thank you very much for your bladder diary. It's been very informative. It looks like it confirms that you are waking up a lot overnight. And gee, you're making a lot of urine. Tell me, what bothers you the most about waking up overnight? Is it because when you wake up, it's very urgent and you're struggling to get there in time? Or is it that it really affects your sleep quality? Is it hard for you to return to sleep after you've woken up? How does it affect you? If the person looks a bit frail, I'll ask about falls. Certainly, if they're a bit younger, I ask about the impact on their daytime performance and then the impact on their partner or carer. So I'll go through a couple of cases to try to illustrate all this. So I've got an 83-year-old gentleman who was referred for nocturia as his primary problem. He's quite a vascular path. He's got all the coronary artery disease, high blood pressure, cholesterol, and COPD. He also had radiotherapy to his prostate about 5 years ago. He has sleep apnea. He was diagnosed 3 years ago, but he is not on a CPAP mask. He's on, amazingly, 5 different antihypertensive medications to control his high blood pressure. So he tells us that he goes to the toilet in the daytime only 3 to 4 times, but overnight he's voiding 7 to 8 times. He really doesn't have any other symptoms. No overactive bladder symptoms, no voiding symptoms to suggest an obstruction. He has no urinary tract infections, bowels opens daily. When we did an examination, we found that his blood pressure was still quite high despite 5 antihypertensive medications, and there was no postural drop. His BMI is quite high at 38. He has a Mallampati score of 3. The Epworth sleepiness scale and stop bang questionnaire were not done for this patient. And then after that, he also had moderate peripheral edema. So let me tell you what the Mallampati score is and the ESS and stop bang. So this is the Mallampati score. This was designed by an anesthetist to work out how easy a person could be intubated during anesthesia. So essentially, it tells us to the surgeons, chill, don't stress. It's quite an easy intubation, or good golly, this is going to be a nightmare. We better make sure we are on the top of our game. So it tells us how crowded the oral cavity is, how large the tongue is, how likely this is going to flop back when the person is lying supine and block up the airway and cause sleep apnea. So even though it's designed for anesthetists for intubation, it has been useful in predicting the likelihood of obstructive sleep apnea. The Epworth Sleepiness Scale is really a scale that that the patient fills up themselves, and really it's about how likely is the person to doze off during the following situations, such as sitting and reading, watching TV, if they are in a passenger in a car, what if they were talking to someone, if they were having a quiet lunch, etc. And so if you score 0, I would never doze off, versus a high chance of dozing, the higher the score, the more likely that you have mild, medium, or severely affected by sleepiness. It doesn't tell you about the cause, just tells you how sleepy you are. Then there's also the stop bang questionnaire that we can sometimes use, and really this works out the risk of obstructive sleep apnea. Do you snore loudly? Do you often feel tired during the day? Has anyone observed you to have apnea? Do you have high blood pressure? The BMI, age, neck circumference. And so if you pick yes to more, then more likely the person is of risk of OSA. Okay, back to the story. So this person, in summary, has nocturia 7 to 8 times, very high blood pressure despite 5 antihypertensives, and looking a bit large, risk of OSA. In fact, has a diagnosis of OSA, but not being treated. So this is the bladder diary that they came in with, and I'll just summarize things. So during the daytime, he has voided anywhere between 50 mils and 130 mils. During the night, he has voided anywhere between 180 mils to 400 mils. And I do apologize, this is actually, we had 2 days worth, but this is just 1. And we calculated that his nocturnal polyuria index was 87%. So this guy makes 87% of his urine during his sleeping hours. His first uninterrupted sleep time is 2 hours, but we also realized that he was drinking 500 mils of fluid overnight because he was thirsty. So what did we do? We said, you know what? You have obstructive sleep apnea. And because sleep apnea, when you close off your airway, it results in hypoxia. The hypoxia will result in pulmonary hypertension, which then results in an atrial stretch. This atrial stretch will then lead to atrial natriuretic peptide, or ANP. And this is a natriuretic peptide, so it causes a diuresis in the kidney. So we know very well that obstructive sleep apnea leads to diuresis overnight. So you need to go onto a CPAP mask. And once we know that once we put a CPAP mask, we can, for many patients where it's effective, you get the right pressures, and if they can keep it on for most of the night, then you will effectively negate the effect of sleep apnea. So in this case, the patient was very agreeable to do so, and they found that each individual voided volume was still about the same, so 50 to 400 mils. But the nocturia now has reduced down to 4, a great improvement. But the nocturnal polyuria index was still quite high, still 73%. But the difference for him was that because he had improved quality of sleep, he is now feeling a lot more refreshed in the day. So he's already quite happy. But we aren't happy in the clinic. We're still thinking, why is this guy still making 70% of his urine at nighttime? So we said, look, maybe he's got a blood pressure problem. He's on 5 antihypertensive and he still can't control his blood pressure. What's going on? So we then requested a 24-hour blood pressure monitor. And so this, I'm just showing this to you so that if you ever come across this, on the blue side here is the person's blood pressure. On the red side here is their heart rate, which is down here. The upper line is the systolic pressure, and the lower line is the diastolic pressure. They've put some reference ranges here for 140 during, and this is the time at the bottom, during the daytime, and then they indicate when the patient has gone to sleep, and then they'll denote the time and when they've woken up. This is the sun. So then this area here is going to be nighttime. Now, physiologically, when we go to sleep, our heart and our brain, when we're lying down in supine, is actually going to be at the same level. So our heart and vascular system should adjust to this and actually not pump so hard. So there should be a dipping blood pressure of somewhere around 10 to 15 millimeters of mercury. That's physiological. However, in this gentleman, even after he's had his CPAP mask on, when he goes to lie supine, his blood pressure actually inverts. It actually goes higher during the supine, in a supine position when he's trying to sleep. So there are some people who have this. Other people that tend to have this are people with autonomic neuropathy, people who have Parkinson's disease have this problem sometimes, and people who have quite bad diabetes, where they have a lot of autonomic instability, where they have postural hypotension. This happens sometimes. So this is what we're clued on to. This is what we look out for. One of the issues is that when we have people who are very hypertensive overnight, they over-diurese through the night. And by the time they wake up in the morning, they're actually relatively dehydrated because they've lost all that fluid overnight that they shouldn't have. And because they're under-volumed the next morning, they have this postural hypotension during the daytime. So this is from the 24-hour blood pressure monitor. They just graph it in a different way. And in this case, you can see that there's a lot of things in the red at nighttime, which tells us that it's too high. These are some of the averages that you can tell during the daytime, and overnight his average blood pressure was 167 versus the daytime, which is 129. The other thing to really look for is right at the bottom, and this is called the dipping. And so we can then look at whether this patient actually dipped. Are they a non-dipper or are they inverted? Okay, so in this case, this chap was actually inverted. His blood pressure is higher when he is lying down to sleep at night, which is not supposed to be the case. So what did we do next? We said to him, take all your antihypertensive medications at nighttime. We also actually added a GTN patch at nighttime. We decided to stop his more diuretic because the hydrochlorothiazide has a very long half-life, and we were wondering whether it was still in some way causing a diuresis, even though it was taken in the morning. Maybe it was still working in the evening and overnight. And we gave him instead furosemide in the late afternoon to try to get it slightly to shift that towards the afternoon. Furosemide is quite short acting, and so usually within about 4 to 6 hours, it should be well and truly done its job. So we also said avoid alcohol, limit your evening fluids, sip only overnight if you're really dry in your mouth. Here's some oral balance gel, and with your peripheral edema, let's use some below-knee compression stockings. And with this concerted effort, the outcome was wonderful. His nocturia was now 2 to 3. His first uninterrupted sleep time was 4 to 4.5 hours, and he was very happy. So the whole this case study really tries to illustrate that there are multiple causes in this gentleman, and really it requires a multi-compartment approach. If we had just done the CPAP, it wouldn't have gotten to this point. If we thought it was an overactive bladder, we wouldn't have gotten to this point. And same thing, if we just treated his blood pressure, you might not have gotten him to a good enough improvement. And it's hard to know when, I'm sure enough, you know, in any one patient, there will be some factors which are more relevant to their presentation, but you don't know that. I don't know that. We just have to try. If we identify it, treat each individual component as best as you can, and then you see how far you get. So nocturia, sometimes the sense is that it's a bit frustrating because the patient comes around to see you, and then they're looking for a quick fix, and you have to go and work out each and individual thing, and you treat each one, and then they have to come back. It's not that one, try another one. And so it takes quite a number of visits before they actually eventually get better. So normally I tell patients this, I put out a map in front of them. I say, this, it could be this, it could be this, it could be this. And then they feel overwhelmed. I said, don't worry, I will be with you. I will hold your hand. You just have to trust me and do what I tell you to do. And I will see you in 2 months from now. I'm not going to wait 6 months to see you again. Maybe even 4 weeks. You sort this out, but I'll see you in 4 weeks. We'll fix the next thing. We'll see you in 4 weeks. We'll fix the next thing. And then I promise you, unless I don't promise anything, I think we will get you better after X number of months. So that's how I try to approach people. Okay, another case study. I'm just conscious of the time. A 75-year-old gentleman referred by urology for medical management of the nocturia because they say to us, he's not obstructed and he has no daytime overactive bladder symptoms. Once again, he's got a couple of cardiac risk factors. He also had a TERP, but then he's had a urethrostenosis, which he was catheterizing every fortnight. Was it 2 times a week? I'm not sure. I can't remember. But essentially, it's not the problem. He's on mirabegron just in case, as when he came around to see us, they said, keep it on the mirabegron until we figure it out. So he has had a 10-year history of nocturia, 3 to 4 voids. He wakes up with a normal urge. He sleeps at 9:30. He wakes up after 1.5 hours, and every 2 hours, TJ, it's like clockwork. I can set essentially every 2 hours I'm up. So this is a Tango screening questionnaire. You may have seen this and heard of this through the conference. It was developed by our colleague at Royal Melbourne, Wendy Bauer. And it really is a useful, I think, screening tool, especially when you don't have a lot of time. Patients can fill this up. And so essentially, there are questions around the cardiac or metabolic systems, the sleep, urinary tract, or well-being domains. And so if they are quite affected, then you see quite a number of ticks here. And if they are absolutely not affected here, you can feel quite confident it's probably not going to be a cardiac or a sleep problem. Then you can then spend much more time and focus in that domain. So it helps to guide you in that way if you're short of time. So last fluids at dinner time, and then after he does not drink any fluid overnight. He drinks 2 cups of coffee, but usually earlier in the day. There's no congestive cardiac failure, no peripheral edema, blood pressure well controlled, no dizziness, no diabetes. He says he falls asleep quite easily, and then he has nocturia and is relatively easy to return to sleep. He says he doesn't think he snores. And when he had a sleep study in 2016, he was told he had no sleep apnea. So I'm at a bit of a dilemma what to do here. I examine him and find that everything is really unremarkable. Blood pressure is 140, no postural drop, no evidence of cardiac failure, no peripheral edema, and here's a bladder diary. And so what we have here is on the 12th of May, this is his daytime voids and then his nighttime voids. So the nocturia in this case is 3, 1, 2, and 3. The first uninterrupted period was 2 to 3 hours, apologies. The nocturnal urine volume total here is 830 mils, plus this amount daytime, a total of 1470 mils. So the nocturnal polyuria index came up as 56%. So I thought maybe it might be a blood pressure problem. So I organized a 24-hour blood pressure monitor, and it's not, I don't think it's the cause. At nighttime, his blood pressure doesn't dip, so it's a non-dipper, and it's throughout the day. His blood pressure is probably averaging at about 130 to maybe 140. At times it goes up a little bit high, but overnight also around 125, 130. So not really, doesn't sound like that's the cause. So in the meantime, I had sent him away for this. I also said I tracked down the sleep study. So I know this is very complicated, and there's no expectation that any one of us will be able to interpret this, but I'll just guide you through this a little bit, which I think may be useful. So this is the sleep hypnogram, the one where we saw at the beginning of this slide. This is wakefulness and REM, and then the stage 1, 2, which is the light stage, and then stage 3 and stage 4 for the deeper stages of sleep. And what we'll see is that this chap is actually just spending all his time in wakefulness and stage 1 and 2 throughout the night. He jumps very quickly 3 and 4 to REM, and then back again this wakefulness. There's a lot of arousals, which means that he's waking himself up a lot. And he's snoring a little bit. There's a lot of what's called periodic limb movement, which is where he twitches or he moves. And it's a bit complicated. Thank you. So now we have the report. And the conclusion was that he had mild positional obstructive sleep apnea, worst in supine REM sleep, which means that he has sleep apnea when he's lying flat on his back and also when he is in REM sleep. So sometimes when it's quite mild, we will just tell people, sleep on your side. I think this will be better than having to deal with a CPAP mask. And if you find that that's effective enough, because otherwise it's quite burdensome. But if we actually look closer, arousals were severely elevated and predominantly associated with periodic limb movement sequences. And it resulted 40% of these periodic limb movements were associated with arousal. He was having 194 essentially twitches per hour, of which 40% of them was waking him up from sleep. So we'll talk, so periodic limb movement is like restless legs syndrome. And in fact, restless leg syndrome is essentially what happens whilst you're awake. But when you go to sleep, then it's called periodic limb movement of sleep, or PLMs. The treatment is quite similar. Well, it's the same, really. You can use things like gabapentin. And in the past, we used to use a medication called pramipexole, which is also known as Cifrol, which is something used for Parkinson's. But now they found that it's safer and better to use things like gabapentin or pregabalin to treat periodic limb movement and restless legs. So once we found this, I brought this gentleman back and I said, here is some pramipexole, because this was quite a number of years ago. But in this day and age, we would be starting to give him some gabapentin, 100 milligrams. But in this case, I gave him the lowest dose of pramipexole at nighttime, and he wrote back to me 2 weeks later. TJ, I took the first tablet on Tuesday night and the second last night. And those 2 evenings are the best sleep I have had for as long as I can remember. And my wife of 50 years agrees. I'm incredibly grateful. Thank you. So his nocturia actually reduced from down to 2. It wasn't a big improvement, but because his sleep quality had improved so markedly, he is so happy. Over the next 6 months, we did a couple of things to test this out. Because he was so thankful, I pushed my luck a little bit and I said, you know what? This would be a very good case study in the future, if you don't mind. He said, if it will help other people, please, by all means, use me as a case study. I said, thank you. So he agreed actually to do a repeat bladder diary for me. I stopped his mirabegron successfully. And we also tried a higher dose of pramipexole, but it really made no difference to him. So we kept it at the lowest possible dose. So here's a couple of things. His nocturia is now 2. His first uninterrupted sleep time is still 2 hours. His nocturnal polyuria index is reduced to 42%, down from 56%. So not that much different. But He's so much happier because the quality of the sleep is different. We repeated his blood pressure, 24-hour blood pressure. And so before this, we have shown you it's sort of up and down quite a bit, especially overnight. But now when he's sleeping better, you can see that the blood pressure is much smoother now, which tells us he's having a very good night's sleep. Even his heart rate is now much smoother. Just to finish up, some practical tips for nocturia. You don't need me to tell you how to look for and manage overactive bladder symptoms. There's the detrusor overactivity, there's the detrusor underactivity, there's the obstruction. But what I think we need to figure out, because these are people that will come to our clinic and they don't know that they have got nocturnal polyuria. Think about their intake, caffeine, alcohol, their peripheral edema, their sugar diabetes. If they are on a medication such as a gliflozin, dapagliflozins or empagliflozins, they cause polyuria by its mechanism, nocturnal hypertension, and obstructive sleep apnea. We haven't talked here about a primary sleep disorder, whether they have PLMs and sleep apnea. Sometimes people are just insomnia. Sometimes they have pain. Some days they have anxiety and depression. But I think usually when you take a general history, you'll figure it out, at least some component of this. But this part here, you'll see in your clinic very much. My top tips are this, okay? In a bladder diary, take what you can. You know, how many people come in with a perfectly filled up bladder diary? You can count with one hand. But you'll get some semblance of information. Take what you can, work with what you have. Nocturnal hypertension, the clues are if they've got Parkinson's or if they have postural hypotension. I say to patients, if you can't keep a full bladder diary, how about you have a bucket? Do all the pee into this bucket overnight. And then in the next morning, when you wake up, tell me how much is in there. At least I will have a sense of the nocturnal urine volume. If this person is passing out 800 mils or 1,000 mils, it's very suggestive of nocturnal polyuria. I also say to them, look, when you wake up overnight to pee, just for these couple of nights, could you take your blood pressure overnight? Could you at least check your blood sugar level at 3 o'clock in the morning when you wake up to pee? I'm not asking you to do it every night, just for 2 or 3 nights, so I get a sense of whether this is a factor or not. 24-hour blood pressure monitors are actually now very accessible. Most pathology services will do it. Certainly in metropolitan Melbourne Pathology, Dorovich, all the standard pathology services will do it. There's a slight out-of-pocket cost of $100. I appreciate that's a cost, but I also try to negotiate with patients. If you can sleep better, it might be worth it. Encourage the CPAP therapy as much as you can, because often patients will give up because it's perceived as too much effort and too bothersome. But when you try to explain to them the benefits, then they may come around or persist a bit longer. And also that the technology with mask is better now and it's less burdensome. So ask them to persist. Other things about nocturia, talk to the spouse or the carer. Sometimes the clues for patients who are very frail or in nursing homes or have dementia is that the staff have to change the pad numerous times because it's full or it's flooded. The other thing I call them, I name them camels, is that they don't pee anything during the daytime, but overnight they pee like crazy. Other things about dementia and BPSD or behaviors of concern. You have to do this in stages. Often I'll treat the prostatic obstruction first, and then I'll treat the OAB with a bit of marabegron. Then I'll look to see if there's nocturnal polyuria. I'll try to treat that. Sometimes I've got to treat some pain. Sometimes I've got to treat some insomnia. And then sometimes eventually we'll have to manage the BPSD pharmacologically because behavioral strategies have not been successful. And my final take-home message for you is that there are often multiple contributing factors and you require a multi-compartment approach to get a satisfactory outcome. Often, if you just treat one compartment, you will not have enough effect and the patient will feel a bit disillusioned. So tell them in advance and then they will work with you because they know that's part of the plan. Thank you.